You're listening to the Physio Matters Podcast in association with Choose Health, and this is session 21. Welcome back to the Physio Matters Podcast with me, Jack Chew. Lots of love across social media for session 20 with Joe Gibson, who managed to simplify a complex condition such as shoulder instability with expert pragmatic delicacy. So, following this, we decided to see just how far we could push the concept of simplifying and clarifying the complex by naming session 21 Fathoming Fibromyalgia. Ahead of cutting to our latest interview, it is an absolute privilege to introduce not one but two therapists who have braved the Physio Matters microphones for this month's episode. It's only taken a 20-episode apprenticeship, but I know you'll share my delight in introducing a new interviewer to the podcast. Rob Tyer, a physiotherapist from sunny Newcastle, has been working hard behind the scenes for Choose Health with a whole host of projects, and because I know how to spoil a man, I treated him to a microphone. For session 21, Rob has a chat with New Zealand-based occupational therapist, or as you will soon hear, pain therapist, Bronnie Thompson, who completed a PhD investigating persistent pain with a special focus on fibromyalgia. Interestingly, Bronnie also has first-hand experience with fibromyalgia as she manages the condition as well as helping others with it in her day job. So, over to Geordie Rob and Kiwi Bronnie for a podcast containing two of the world's most beautiful accents, slightly in contrast to usual.
For the listeners, Bronnie, who might not be aware of your work, could you give us an overview of your background and how you came to develop a special interest in fibromyalgia?
My background is occupational therapy with a hefty dash of psychology, and I've been teaching and working in chronic pain management for most of my clinical career. And I got interested in fibromyalgia partly because we had so many people coming through our centre who had fibromyalgia as their diagnosis. And it was only after, probably nearly 20 years of pain myself that I actually joined the dots and identified that that's in fact what I had as well. So I've become quite interested in it. It's also really the archetypal central sensitization disorder, or as Wolf calls it, the dysfunctional pain disorder. So it represents a really interesting problem clinically.
So yeah, that's definitely quite interesting. So much so that I think there are a few clinicians out there that probably behind closed doors will discuss whether fibromyalgia actually exists as a distinct entity itself or whether it is part of a spectrum of chronic pain disorders. I mean, what are your thoughts on that, Bronnie?
I think it probably is part of a spectrum, and that's because I think while there are certain clinical features that mean that this person gets the diagnosis, meets the criteria, there are other people who have nearly all the symptoms who couldn't get given the label but actually fall neatly under that heading in terms of management. And the management and some of the key problems in this cluster of disorders, which includes things like, Muhammad Yunus wrote about temporomandibular joint dysfunction, dysmenorrhea, irritable bowel syndrome, that kind of spectrum of disorders that have the central sensitization component. And I think that you can have a range of problems that fall into this. So some people might present with primarily fatigue and a feeling of heaviness and lack of get up and go, while others will present with classic tender points and all the bits. The pain that moves from place to place in the body, as well as the poor sleep and the poor concentration and some of the other psychological symptoms. So I think it really is a spectrum disorder. Having said that, fibromyalgia is a convenient label that people adopt because it sort of describes what's happening, which is pain, myalgia, pain in the muscles, and I guess the fibro part was really looking at those muscle fibres.
Do you find that label is almost essential for some people, or do you find that that the label can almost hinder the progression of some people with the condition?
In the research that I did for my PhD, looking at the need for a diagnosis, it seems that that is something that people really need. They need to have a label, not so much for what the label is, but to represent that this is something that is understood, that it's identifiable, that it's real and valid. Whereas without a label, then people are still searching for somebody to acknowledge that this thing that they're experiencing is actually real. So I think there's value in having a label for it. There are some people who don't want to give out a diagnosis for fibromyalgia because they believe this is going to sort of suck them down into this nasty vortex of being a fibromyalgia patient and somebody who's never going to recover and all that sort of thing. But my experience is that it enables people to match their own experience with the description that they would read on the internet or from diagnostic categories and feel satisfied that somebody knows that this thing actually exists. That's really important because it helps people feel certain of the prognosis, certain of the management, and really validated that their experience isn't, they're not going nuts, they're not pathetic or weak or just, pulling the wool over everybody's eyes, and they actually know that it is an entity in itself. So I think there's a real value in giving it a label.
That's great. On that label, on that sort of direction you've discussed there with patients trawling through the internet, it's a very interesting sort of time that we work in as clinicians now, whereby access to information has never been so available. Do you find that sometimes some of the forums that patients get onto help them with the coping strategies? Or do you think that it can almost reinforce that learned helplessness by surrounding themselves with others who are explaining their pathway to get the diagnosis as nobody believes me, it's taken me several hundred different consultations to get to where I am now? Absolutely.
I think there's a risk with support groups of any kind that they can become pity parties. And it's poor me and woe is me, and the membership of these groups changes, and as the membership changes, then the nature of the groups also often change. I think there's some value for some people in being able to know that they can talk amongst people who know what it's like, share experiences, compare things, and get that sense of I'm not alone in this. But there's also a risk that it can become rather depressing and pulls a person under. And it's really a stage, I suppose, in the readiness to accept and then to move on in dealing with the fact that you do have a long-standing disorder. I think that's for people who are prepared to move forward, who think, yes, I've got life, I might not be able to get a fix for this disorder, but I still want to live, then it's probably they'll find that they get fairly fed up with the support groups and move on. But those who are resentful or don't feel heard or listened or validated, then it can be a really good place for them to wallow. I'm a little bit cynical about them, I suppose, because I've seen some fairly bad ones go down, but I've also seen that there are some really good ways to connect. I suppose the Pain Toolkit community is a really good example of one that's getting really supportive, and people are learning.
Like Peter Moore.
Yeah. So people are learning from one another there in a positive way. And Pain BC has also is developing a similar sort of community in Canada. And so there's some, in those instances, it's like there are pain heroes who are saying, look, I've got through this. I've managed to move forward. And that is a really nice thing. It's when everybody's in the same depressed, horrible boat that it's not quite so positive.
Yeah, and you mentioned sort of people saying, "Oh, I've managed to get through this." That's an interesting choice of words, especially seeing as the most recent work that I've read by yourself on your health skills site was the blog article on fibromyalgia. When is it treatment and when is it management? I'd just be interested to hear your thoughts on, well, firstly, when is it treatment and when is it management, and also who is it that makes that decision?
Good question. And I think it's very difficult to tell exactly. We can't sort of put a line in the sand and say, at this date, everything should be focusing on management. But I do think there's also a temptation as clinicians to not want to be the bearer of bad news. On the receiving end, people have told me about this cycle of hope and then despair as they get offered the treatment that will take all my pain away, and then the despair when it doesn't work. And that cycle prolongs distress and disability because people put their lives on hold hoping that they can get back to normal. And when it doesn't happen, at some point some people decide, I'm going to move on anyway. I'm going to get on with life. But there are another lot of people who don't, and they're the people that we tend to see in tertiary pain management centres who go around the hoops and trying to find something that will take it all away. The current understanding of fibromyalgia is that it is a management problem rather than a curative problem, because it's probably associated with a number of changes in the central nervous system, particularly descending noxious inhibitory control, but also additional substance P being flourished around and more connectivity between various parts of the brain. There seems to be some changes that we're not sure if they are pre-existing, so they cause the problem, or they're in response to something else that's gone awry. But it does seem to be something that we're going to need to manage rather than try and fix. Having said that, there are some treatments that for some people will work really well. And I guess the pharmacological treatments for some people find that tricyclic antidepressants are just a miracle drug. They have no pain and they have good sleep and they're feeling absolutely chipper. Others find that that doesn't work. And so they are really the mainstream treatments for most people with fibromyalgia are find a good exercise that you like to do, learn as much as you can about what sets your pain off, what settles it down, and live well and sort of live around it. And that's a CBT approach rather than a CBT therapy. And
that's something that I suppose could be applied to most every condition we see, whether it be a complex chronic pain condition or an acute ankle sprain. Find something that works, get yourself moving as best you can. I'm just interested to know, because on that same health skills site, that same blog, you referenced work by Wolf, who suggested that the neuropathic pain meds were maybe not as widely effective as we'd like them to be, and it sometimes takes 1 in 4 patients to find somebody who only has a 50% pain reduction. And I suppose I use the word only, and if I lived with chronic persistent pain, I'd take anything I could get. But is there some sort of, or do you think there is a scope to develop some sort of categorization or subcategorization of people who will likely benefit from that? So rather than wasting time or potentially having the negative consequences, such as drowsiness, of taking the tricyclics, do you think there's a better way of identifying those who it'll help?
Doesn't seem to be at this point. There's certainly some genetic factors involved in fibromyalgia, and there are also genetic factors involved in how we metabolize certain tricyclics. So we have some people who are super metabolizers who need a really small amount of a tricyclic to get a really massive effect. So they'll need teeny tiny little doses, whereas others don't metabolize it very well and need massive doses to get the same effect in the plasma as those people who metabolize it very, very, very well. But unless we do genotyping, which we tend not to do, cost, and it's relatively, especially in New Zealand, it's not easy to do. It's just as easy to try medications. So the practice in Burwood Pain Management Centre, where I've worked, is to trial things and to give people a really good trial of. Usually we start off with a tricyclic like nortriptyline, give it a good 6 weeks, perhaps a little bit longer, titrating the dose up until we've got get a sufficient amount in the plasma, so a therapeutic dose in the plasma, so take blood tests. And then if that hasn't affected anything, usually gabapentin or something like that will be added to the dose, and again that will be titrated up until the side effects aren't very nice or it's actually effective. And that, as Dr John Alchin, who's the pain physician at Burwood, says, it's really an empirical test. We actually need to try it to see whether it's going to have an effect. And in a lot of ways, I think that's the same for all of our pain management. We don't know until we try something with that person to find out if that fits for that person in that context, in their lifestyle, because we can't really subtype particularly well when it comes to something like fibro.
Yeah, it's a difficult thing to do in a lot of cohorts, isn't it? The subcategorization. I think from an academic point of view, it certainly would make our lives a lot easier. But I think we have to remember we're dealing with people at the end of the day.
Yeah, and their individual thoughts and beliefs are as important as whatever genotypes or phenotypes they have. So we've got to be aware not only of the biology, but also of the psychology and the sociology of their lives, which is really a whole lot more complicated than setting a fracture, isn't it?
You could say that for sure. And you mentioned that the psychology side of things is hugely important. And I know off the interview we discussed a while ago about the differences in country to country as to who was involved in making the fibromyalgia diagnoses. And I wondered what your experiences were, because certainly in the UK, when fibromyalgia patients come into my clinic, they often have gone through this sort of American College of Rheumatology 11 trigger point tender sites alongside some of the other symptoms that you would expect, but only after having gone through a diagnosis of exclusion. Is that something you still experience in New Zealand, or is it evolving at all?
Yeah, the Canadians put out a guidelines, I think it was last year or the year before, looking at pushing the diagnosis out into the community to primary care. So while they still endorse doing your excluding potential other diagnosis through blood tests, you can't test for fibromyalgia. There's no lab test that will do that. So they're instead suggesting that GPs should use the Fibromyalgia Impact Questionnaire, do the exclusionary bloods, looking for hypothyroidism and inflammatory markers and such like. But otherwise, they're saying if this person says I've got widespread pain and I can't sleep very well and I get this sort of foggy feeling and I've got the score over a certain number, then the chances are very high that this person's got fibromyalgia. But they published the rationale for the shift to using the Fibromyalgia Impact Questionnaire to move away from the tender points, because they found that some people had profound symptoms of poor concentration, that fibro fog, feeling really fatigued and really poor sleep, but maybe didn't have 11 of the 18 points, tender points. Instead, they had maybe 9. But what's 2 to 4 tender points? Given that we don't really know what tender points are, and I'm not even going to start that discussion now, it seems that that's not a very accurate measure of pain. It's just yet another sign that can be used. Most people who have fibromyalgia will have tender points at least somewhere, but it seems like that figure wasn't as clear as they thought.
So do you think it's been mainly based on historical dogma and kind of push forward just because it's always been done?
I think it's probably been by consensus, and we know consensus is not a very clear thing. There are lots of factors at work when people need to sit down in a team and make up their minds. But it seems, certainly at least in the Canadian guidelines, that that's the idea, is to try and push it out to the community, because one of their arguments at least was that the GPs are the ones who will most likely be doing the majority of managing. Given that there are very few options from a pharmacological point of view, and most of the management is going to be symptomatic, so some exercise, some work around sleep management, some work around coping with fatigue and stress. It's more likely to be a GP's work than it is to be a rheumatologist's work.
Do you find that, I don't know if you have much contact with GPs, and I'm not exactly sure what kind of professionals you surround yourself with at work, Bronnie. Do you find that GPs are a little bit more open to this idea of fibromyalgia, or because you seem to find that most resistance seems to come from certain cohorts of our profession? Yeah,
I think in New Zealand it's a little bit different. I think that the GPs are fairly open to. They've had a lot of education in New Zealand from ACC, our compensation organisation, that has been able to differentiate between what's compensable and what's not. So if somebody presents with fibromyalgia that hasn't had an initiating event, they haven't been carrying something, and then all of a sudden they've got this widespread pain, they've had to be ACC has had to push the idea that fibromyalgia is distinct from low back pain that's become chronic. So I think that's partly why it's a little bit more, people are a little bit more aware of it. As far as the physiotherapy fraternity in New Zealand, I think there's general acceptance, but confusion. What do we do with somebody who's really sore and for whom exercise doesn't produce the usual reduction in pain?
So I suppose before we get on to the what do we do with them, I think what I would like to know, especially considering where I work, it's patients can self-refer into physiotherapy and bypass the GP altogether. Yep. So if that patient is on my doorstep as a first point of access, is there a better system of clinical reasoning that doesn't rely so heavily on this diagnosis of exclusion? Is there something that would raise my index of suspicion that this person is likely to be someone who will end up with a diagnosis of fibromyalgia?
Yep. I would say if somebody says, look, I just ache all over, my body hurts everywhere, I'm really tired, I'm not sleeping well, or I'm sleeping a lot and I just don't wake feeling like I've had a sleep, that I can't really think straight, and I'm feeling low and just a bit fed up, really, then I'd be, particularly somebody who says actually all of my body hurts. There's not one part of my body that doesn't hurt at some point. Many people with fibromyalgia describe not wanting to go and seek help because they have a pain in the shoulder, and then they have a pain in the leg, and then they have a low back pain, and then they have a neck pain, and then they've got a belly pain. It's pain shifts around the body, but is usually present in all four quadrants of the body, and that's probably the hallmark of fibromyalgia, alongside the sleep and this cognitive change. So those be, anyone says I'm sore everywhere, I'd be thinking, I think something's going on here.
And is that something that you would jump on immediately? Because I know I've certainly made the mistake in being a bit over-enthusiastic in trying to instigate onward referral. Would you discuss it openly with the patient and say, should we play this by ear a little bit and see how your symptoms change? Because I know certainly with some kind of rheumatological conditions, they want you to have had the symptoms for at least 3 months consistently before they can kind of say, yes, for sure, this is condition X?
I think it's pretty much the same with fibromyalgia. I'm just skimming through. I can't remember how long the symptoms need to be present for, but generally people won't be seeking help until it's been present for a good 3 to 6 months. That's the nature of the clientele, I suppose. Usually women, usually in their 30s to 50s, I suppose. And often they're worried that people will think that it's that they're depressed and they just need treatment for depression and that's all you need. But that doesn't explain the fatigue and the poor sleep. I would say give it a go. There's some important points about exercise, though, that need to be borne in mind. Because for most people, when we've got chronic pain, when we start to exercise, we get a nice, fairly immediate reduction in pain fairly soon afterwards. It's related to our descending inhibitory mechanisms. Fibromyalgia, the opposite happens. It actually increases pain. So that's a problem for us with fibromyalgia because it's hard we have to start at a very low level and gradually build up exercise tolerance. And that's, it's thought that it's about this central descending nociceptive inhibition that doesn't appear for people with fibromyalgia. Other people, yes, but not fibro. Just to go into a little bit more detail, in healthy people who do some aerobic exercise, getting up to 70% VO2, they get pain inhibition for about 30 minutes post-exercise. Resistance exercise does the same. But for people with fibro, instead of getting that decrease in pain in that 30-minute window, it actually goes right up. As well as they can feel really, really fatigued and just overwhelmed with, I just can't move, just feel absolutely shattered. And that's, one of the reasons we want people to be able to exercise is to increase their tolerance to doing things. But if we go too far, too fast with people with fibro, they get this immediately negative response. That's not the best way to get someone enthusiastic about exercise. So we need to start on things that are a little bit gentler. And do very low levels and very quietly sneak it up so that it doesn't have that nasty rebound effect.
Do you think there's a limit as to how far that can go? Can someone with fibromyalgia, say, be an elite athlete?
I'm not sure. I haven't heard of any people with fibromyalgia being elite athletes, although I wouldn't be surprised given that we have some very, very fine athletes who have got rheumatological disorders. I guess I wouldn't put fibro as a rheumatological disorder anymore. I think it's probably more of a neurological disorder, but I'll probably have chorus of groans from people about that. But it doesn't have the inflammatory kinds of responses. We know that there are some very fine athletes who have got ankylosing spondylitis, for example. But people with fibro will tend to have to build up to their level and then maintain that consistently to be able to do something like a race. Otherwise, there's definite payback. DOMS that goes on for a week or two.
Yeah, and that was something we talked about off mic as well, the DOMS aspect of things. And with this being something that has DOMS which would last longer than you'd expect in people without fibromyalgia following exercise, and you mentioned in there that you think it's kind of moved away from the realm of rheumatology and now into the realm of neurology. Do you think there's a role to play in the model that Tim Noakes proposed on the central governor for fatigue?
There could be. It seems like the two disorders are similar in some senses. Certainly there's the idea that you monitor your fatigue levels and work inside your fatigue levels isn't a very good idea for people with fibro. They need to go just a little outside that fatigue, but not that far. So it's like walking on a tightrope.
So to go just before it rather than the other side of the fatigue.
So if you think that you can comfortably manage 10 minutes, then you could go for 11 or 12 maybe.
Okay.
But not to stay underneath the 10 minutes, because if 10 minutes is your limit and you consistently go under, you're not going to get fitter or stronger and build up that tolerance. So it's got to be very tiny incremental increases.
And do you think this would be something that is the case for most all people with fibromyalgia, or do you think there is that subcategory within fibromyalgia which are quite heavily linked with chronic fatigue syndrome?
Fatigue's certainly part of fibromyalgia. So yeah, I think it's a spectrum. So for some people, the fatigue part's going to be the predominant feature. For others, it's going to be the pain part. And then for others who've got it really badly, they'll have both. Which is a bit cruel, really. But,
as if it wasn't bad enough, I suppose.
But I think the things that seem to be useful are to be repetitive type movements, things like Tai Chi, yoga, things with lots of stretching. Swimming seems to be really popular. I dance, but I also garden and things as well. So for me, running is definitely out, and I'm not going to climb up hills. I'll go down, but I'm not that keen on going up hills. I'm quite happy to lift weights if I have to, but that's not something that I'm going to enjoy as much as I would enjoy dancing. But yoga is great.
And do you think that maybe that is the element there, though, that is our own biases as people, that, you know, some people do enjoy lifting heavy objects, some people don't enjoy walking and prefer to run? Do you think that we need to be more patient-centric in that case?
Totally.
You know, as the
because we know
with the guidelines for lower back pain, we suggest that we do any form of exercise rather than, you know, well, you must run, otherwise you won't get better.
Exactly, and I think that's the key. It's got to be something somebody enjoys doing, otherwise they won't bother doing it. And at this stage, there don't seem to be any particular forms of exercise that are any better, although it does seem that for women who have fibromyalgia, that they prefer the fluid kind of movements rather than the fast, jerky kind of movements. That fluid movements seem to be a little bit easier to tolerate.
Is there a mindfulness component to that, do you think?
I think mindfulness is just great anyway. I don't know that that's part of the reason why people like Tai Chi and yoga. I think it's more that the movements are smooth, they're flowing, they're not jerky, they're because it seems to be that jerky movement, the fast twitch fibres that seem to be the problem a bit more for people with fibro. But then people do enjoy swimming.
So you think that maybe there is a muscular component to that in the muscle type that's required for the activity, rather than, say, the potential increased risk of lifting a heavy object above your head and the consequences of, when you're fatigued, not being able to achieve that. Whereas the things like Tai Chi and yoga are very structured. You know what's coming next. You've done this before. You know you're safe to complete that activity.
Well, it seems like they're saying in one of the papers that exercises associated with myofiber damage and substance released in response to exercise potentially provide increased nociceptive input. So if you're doing really fast, jerky movements that are inclined to bring on that kind of muscle fibre change, I would expect that is going to be less comfortable and pleasant than something that's smooth and sustained and more about control and sort of form. The other thing is that because fibromyalgia tends to make bodies feel sore everywhere, the being able to be selective and get really good poses and things like Tai Chi and yoga would give a better kinesthetic awareness of what's going on in the body. And so I think maybe there is some role for that, kind of becoming aware of the body. The mindfulness, I suppose, could be helpful as well.
I suppose it goes back to what you were saying as well, that in some patient populations with fibro, they've been found to have a higher level of substance P or blood cytokines. And if you're going to go down a route of eccentric ballistic exercise, which has been known to raise those chemicals post-exercise, possibly that's not something that the body that is sensitized is interested in experiencing.
Exactly. And then I think too, if people are starting exercise and they haven't been exercising at all, if we can avoid anything that does increase pain too much by doing these more gentle type exercises, I think that's going to probably increase the chances of the person actually carrying on with it. That's a good thing.
I think you've kind of already answered the next question I was going to go on to about exercise, so I don't think we need to sort of dwell too much more on that, but that's really interesting. But I think the flip side of the coin would be there has been some suggestion that the heavy reliance on neuroscience and pain education with patients is tantamount to patient blaming and inherent laziness from therapists who are just basically giving up on finding the cause. What do you find this is a complacency in practice that we have just given up on finding the cause, or do you suggest that people making these assumptions are just ignorant to the modern understanding of pain in general?
I think you'll always get some people who will try and track down the source of the nociception, but my fear if that happens is that this delays the time that the person has before they realise that this is actually what I've got, this is what it is. So if it takes, say we have to do diagnostic blocks, and I've personally seen a patient who had a whole year of diagnostic blocks going from level to level to level to find the source of the nociception, only to not find anything. And that was a whole year where she wasn't able to work in her normal job, and she was hoping to get back to what she had been like prior to the onset of her pain. And to me, that's devastating. We know the outcomes of people not returning to work within a year. We know that going back to work becomes increasingly hard. So if we have to delay doing things, getting involved in the rest of rehabilitation and perhaps learning how to manage pain in that time because we're hoping to find the cause, that's like taking people down a path that is going to be disabling simply because they can't engage in those things that we know are helpful, like returning to work. So I think some people are wanting to be heroic, finding the cause, and I would hope that if there's no clear-cut guide or clear-cut clue suggesting there is a focal lesion or something that can be treated, let's do some basic stuff like let's get your big muscles moving, let's get you engaged in things that make your life worth living rather than holding off on the hope that you'll find something that's going to take it all away.
And that's interesting because that, again, it's probably not unique to fibromyalgia, is it? Whereby we need to try and understand the limitations of somebody in front of us and build something that they're happy to engage and almost make that shared decision making between the therapist and the patient to try and get them back to function. And as much as there are clinicians out there who are looking for the lesion or looking for the mechanical structure to reposition or put back in place, there are always going to be patients out there who will accommodate that because they are, as we mentioned before, therapist hopping in order to find someone who says the things that they want to hear. So with the sort of more modern application of neuroscience education, do you think that we can arguably stand by it? Has there been any demonstrable changes in the quality of care of patients, or actually are we kind of going down a route of anecdote rather than evidence-based practice?
I think there's real value in helping people understand their pain. In my research, I looked at people understanding their diagnosis and knowing what their diagnosis was. This is their process of getting towards making a decision to get on with life. People needed to know what they had. They needed to know, what's the prognosis? Is it going to go away? What do I need to do? They needed to know the shape and form of their symptoms, the things that set their pain off and the things that settle them down, the time of day when they're feeling their best and the time of the day when they're not. And they also need to know what that means in terms of making predictions about what they can and can't do. So that's without setting new goals. They need to understand, so on a bad day, it's probably not the best idea that I vacuum the entire house. On a bad day, I might be better off to maybe do the dusting and vacuum half the house, rather than trying to do everything the way that they've always done. And that process of working out what you can and what you can't do helps people make sense of their pain. Everybody needs that, to be able to understand what they can and what they can't do without setting everything alight. I think neuroscience education helps people get an understanding that this is just noise. But neuroscience education on its own isn't sufficient. As we say, Bill Fordyce, who's sort of the father of behavioural approaches to pain management, said that information as to behaviour change as spaghetti is to a brick. Saying that you can tell people that this is not harmful. You can tell people that this is just your sensitive nervous system. But until people start doing things, it's not going to really register. So I think there's a risk in suggesting to people that, well, we've explained it to you, so why are you still bothered?
You often find, or I certainly did when I adopted this quest to try and understand some of the pain mechanisms behind why people hurt, that you often get the, maybe not verbally, but the what next question or the what now. So patients maybe, once I've become competent in communicating why I think things are happening, they go, that's great, Rob.
Now what?
What now?
Yeah. And I guess what we found at Burwood over the probably last few, probably 10 years or so, 5 years I would say actually, we found that we give everybody that comes into Burwood a battery of questionnaires. One of them is the Tampa Kinesiophobia scale. So that's got two scales on it. One is activity avoidance, and the other one is about the fear of re-injury. So what we found was that people are saying that I'm not bothered about fear of injuring myself again. I'm not that worried about it anymore, but I'm not going to do it. So their activity avoidance scores was very high still, despite their actual cognitive understanding of what's going on being quite low. So this suggests that we need to start doing things, and graded exposure or getting people to begin at a level that they can do and gradually building it up, doing more variety of movements and different positions, different places, generalising that ability is something that I think that occupational therapists and physiotherapists are particularly good at doing. Getting people to do interesting movements in interesting places with the security blanket of knowing that they've got a clinician who's looking after them, looking at safeguarding them, and then getting out to do that in the real world. And I think that's something that we really need to focus on, not just the explain pain, no pain kind of thing, but also the doing part. It's just as important.
Do you think that you're at a distinct advantage, Bronnie, if you want to call it that, I suppose, by also being a patient and having that ability to relate to people and saying, obviously I don't know what your experiences are, but my experiences are this. Do you think a therapist needs to have had some sort of problems like that in the past in order to really empathise with the patient and get them on board?
Yeah, I would have said a few years ago, no, you don't need it. Like you don't need to be an alcoholic to be able to talk to people about drug abuse and alcohol abuse. So you can have the skills, but I do think there is something about being able to say, well, look, it's not easy. We're talking about acceptance. I often say to people, look, acceptance just means that you agree that it's here and you're not going to fight against it, but it doesn't mean you have to like it. So it's okay for me to be honest and real and say, look, there are some things I really hate doing. I'm a lousy pacer. I'm really bad at it. I tend to boom and bust, and I tend to push myself. That's my habit. I don't know whether that gives me greater authenticity, but I do understand the difficulty of trying to apply this stuff in a real world where, I travelled to Brussels via Dubai. It was a very, very long way from New Zealand. And, I was really sore by the end of that. And you can't pace. You just can't, break up your journey that much. Not when you're booking a week ahead of the flight that you're going on. So
no, I suppose you're at the mercy of the pilot, really, aren't you?
So the reality is that in the real world, people will pick and choose the bits that fit in their life. The bit that I can bring is to validate that, saying as a patient, as somebody who experiences pain, I don't think I'm a patient really, I'm a person who lives with pain. I know that sometimes I have to compromise on things. Sometimes I choose not to because it suits me. And what we offer as clinicians is the opportunity to have some choices instead of falling into the same old patterns and not knowing how to get out of it. And that applies to whether you have pain yourself as a clinician or not. Your job's there to say, here's something you could try. Let's have an experiment together and you see how it works. Because in the end, we're not going to have people with us forever, hopefully. They're going to go away and they will drop the things that don't make sense or don't fit in their lifestyle. And that's fine because they'll pick up other things that do make sense. And we don't have to effect miracles. We just offer some options to people. So I guess there are some advantages to knowing what it's like to have pain. But we've all had pain. Only difference with my pain is that it doesn't go away. And so we can use that to listen carefully to what this person's saying. And if you don't have pain, that's fine. You still have to listen very carefully to what this person's saying to hear the underlying things that they're not talking about or the things that they are concerned about.
And you mentioned that, eventually patients will go away to self-manage and things. There is some talk by some clinicians who suggest that should they be left to self-manage, we wouldn't necessarily completely sever ties with a patient with diabetes, for example, who may need regular checkups, who may need monitoring or a little top-up in terms of their coping strategies, or should it be an open system whereby the patient has the option to return should they feel like they're struggling, or do you think that?
Good question.
That is necessarily.
I think there's different levels of readiness. So I think people will pick up what they're ready for at the time they first encounter you, but then they may at another point be ready for something else. I think there is some advantage in top-ups, if you like. I don't know that certainly in New Zealand you would find it hard to get back into a service in a lot of places because we don't have enough services, and I don't think we're unique in that. So
definitely not.
So I think that the ideal is that people can self-manage. The reality is that many don't, and that's because we just don't have people aren't at the right stage of being ready to pick up and run with stuff. But also they get a lot of mixed messages in the community. We just look online and just type in pain and you'll just bring up this huge range of cure this and magnet that and crystal that, and there is everything out there. And it's and if somebody has a flare-up and they go to their GP and the GP reinforces the use of medication rather than actually you've got the coping strategies, and the GP does that because it takes time to talk somebody through how to use coping strategies. If the GP is familiar with coping strategies anyway, it's no wonder that people fail to use strategies as often as perhaps they might. So maybe there is a place for, not a revolving door exactly, but some refresher courses. And the risk is that people will then get sucked into, we'll come along for your 6-monthly tune-up, and I'm not sure that that's a good option either.
No, it's a fine balance between active management and passive dependency, I suppose. Yeah. And I think Pete Moore's toolkit, that I've certainly used it personally with a lot of patients, and the one that I find very successful is building a support network. Yeah. That's quite a good step that he instigates, and often bringing in partners or family members so that there's a second pair of eyes and ears in the room, so that when the patient goes home, their partner can go, well, maybe that's not what he meant by that, or actually remember when he said this, have you tried doing that? So there's that refresher at home.
I think that's really, really important, because if we talk to ED clinicians, and I've had a couple of ED doctors come in to do the courses that I teach, and they talk about these people coming in, with their flare-up of whatever it is, and often it's not the person who's asked to come in, it's their partner who's afraid, who doesn't know what to do, who's scared, and really wants to be reassured. So it's really handy to have both partners there and other family members. I develop a can cope card for people for flare-ups, and on that can cope card, at the top is always stop, breathe out, and then a nice calming saying. But somewhere in there is always the name and phone number of somebody that they feel they can talk to about how to keep going, to delay that need to go and seek, medical or healthcare help, just so that there is something tangible and someone who's in the know as to what to do and say. I think that's very good. My main reason for suggesting that people don't keep coming back for treatment is that it leads to thinking of yourself as being unwell. People with pain aren't unwell. They've got pain. They're normal people who just happen to have pain. And if we think of people living with pain as patients, we'll treat them as if they're patients and therefore sick and needing help, when most people, most of the time, manage really well. We just happen to see people at the time of their need, and maybe we can promote people's independence and self-efficacy by giving them those tools to be able to manage for themselves.
Do you think there's almost a role that's adopted by some people in that sense? Because I certainly find that when patients come in with partners, and the first thing I ask them to do may, for example, be, can you show me how you take your shoes off or bend down? And you find that it's actually the partner that starts wincing and making painful noises. And sometimes you have to have that discussion with the partner and say, look, this is not necessarily helpful. We don't need to wrap this person in cotton wool. Yeah. And that reinforces that pain behaviour of when they come down the stairs in the morning, hi Bronnie, how's your pain today?
It's the last thing I want to be talk about in the morning is how I'm feeling. Yeah, I agree. I think that there's a lot of the social part. We talk a lot about the psychological aspects of managing pain, but we don't talk nearly as often about the social part. And the social part includes the family, partners, but it's also societal and our attitudes and beliefs about pain. So, we have to shift our perspective to help change the awareness of pain in our communities, and also to make it okay for people to say, it's my pain, I'll deal with it, and I'll tell you if I need help or want help. Otherwise, it's like my blood pressure. You don't ask about my blood pressure every day when I come down the stairs.
Yeah.
And, diabetes, we check on glucose levels because there will be adverse effects if we don't. With pain, the adverse effects are really if somebody's not doing things. So really we probably don't need to check very often. Most people have got a life to live. I think we could do more by encouraging people to get a passion and start doing it. My favourite patient or person in my research was a guy who just loves to play rugby, and at 60-something, just loves playing rugby. He's in Masters rugby. He actually wasn't playing when I talked to him because he'd broken his shoulder, done his shoulder clavicle when he'd been playing. But otherwise, that's what he did. He just found that was the thing that kept him going. And he's a guy with osteoarthritis in his knees and hips, and he, at the age of 19 had been told, you shouldn't be playing rugby. You should stop.
Yeah, I don't know if you had the opportunity to hear the podcast with Tom Goom and Matt Phillips with regards to why are people running. Sometimes it's an escapism, and there's certainly a lot of things out there online at the minute with regards to these invisible illnesses that people don't necessarily see, and that, I found that's helpful to raise awareness, but I think we're certainly at the early stages of that. But just out of interest, Bronnie, I've spoken to Mike Stewart, and he says that you've got some very interesting thoughts on the future evolution of clinical practice with those with chronic pain or fibromyalgia. Could you elaborate on that a little bit?
Well, I think what Mike and I have talked about is the fact that between us, we do pretty much the same thing. I'm an occupational therapist by training with a hefty dose of psychology. He's a physiotherapist, and we really do the same thing. And I guess I'm thinking that over time, we need to recognise that there are more commonalities between our specialties than differences. And while I don't want to stop my focus on function, in the end, we're doing so much similar that perhaps we need to develop and refine those skills a little bit more and have some recognition for that, to show that we're actually really skilled in pain management, which is why I like to be called a pain therapist rather than an occupational therapist. Because when we look at exercise for chronic pain, most of the literature says it doesn't really matter what you do as long as you do something. I can probably prescribe doing something. I can go play, I can go garden, I can probably go swimming, I can, those sorts of things are not super difficult to do. And I know really good physios who are just as concerned about whether this person can drive their car as I am about this person's ability to do a semi-squat. Those are the sorts of where we're really working together in an interdisciplinary model. I think that's really exciting. It means that we can really overlap with one another and support one another a whole lot more. And that's got to be good for our clients or our patients, because at the moment they fall through gaps because, I don't want to talk about medication because that's the pharmacist's job or the doctor's job. But we know that patients don't talk to the people that they're supposed to talk to. They will talk to the OT about the exercise because they don't want to talk to the physio because they're not doing them. They want to talk to the physio about their medications because they don't really want to talk to the doctor. And the more that we can cross-fertilise, the better it is for that seamless care that we really want to be able to deliver to people. So that's my prediction. I have a lot more in common with Mike as a physio than I do with my colleagues who are occupational therapists who don't work in pain. I don't know how to do a housing mod. It's not something I touch. I don't know anything about wheelchairs or raised toilet seats. That's not what I do. But Mike and I, we work really, really similarly. And I think Mike would say the same. There's a lot of physio that he doesn't do. Who wants to do green gunk out of people's chests? Really? It's a very special person who does that. And it's not me.
I suppose it's the patient that dictates the specialty then,
yeah.
isn't it?
In New Zealand, we have a thing called an activity-focused program, which involves usually somebody from a psychosocial perspective, somebody from a physical movement perspective, and somebody who says, well, where are you going to use this? And it may be 3 people, or it may be 2 people, but it's often a psychologist, a physiotherapist, and an occupational therapist who work together with this person. And that's, maybe we don't need all 3, maybe we just need 2. I don't know. But it means that when we can overlap and we can integrate our care, and that means that the planning is much cleaner, the patient's always getting that consistent message, and I think that we're able to make a better plan for helping the person take on their own management in the long run.
I think that's a great place to wrap it up, Bronnie. We've certainly explored a few concepts that I know I'll be finding very useful to integrate into clinical practice. But just so everybody else can have the benefit of some of the resources you put out there, would you like to tell everybody how they can find out more about you and what you do?
Yeah, come to Health Skills weblog, and that's a WordPress weblog, or you can always come online to Facebook, where I'm Bronnie Lennox Thompson, or on Twitter as Ademus Free. But if you see Mike Stewart, No Pain Mike, or these guys, you'll find me lurking somewhere nearby. So I'm always around.
That's great, and I'd certainly recommend people do take the opportunity to read the Health Skills blog. I've certainly got a lot of information built by Bronnie on this, so I'd definitely check that out if you can. So yeah, thank you very much for joining us, Bronnie, and hopefully we can maybe get you back on in the future to explore some of the other interesting ideas Mike says you've got.
Maybe we should get Mike and I. That'll be fun.
That might not be a bad show, actually.
Yeah.
And that was session 21. Many thanks to Rob and, of course, Dr Bronnie Thompson for tackling what is a very tricky topic. I think it would be a little bit strange for me to try and summarise the session. So instead, let's get the man of the moment, Rob Tyer, back on the microphones to chat about how it went. So do I have the now famous Rob Tyer on the phone?
I suppose so, yes. Yes, you do.
Well, mate, just... thanks so much for recording your first interview. How did it go?
Yeah, it was a bit daunting, big shoes to fill, but Bronnie made it very easy. She got a good knowledge base, and I kind of just let her go and chirped in whenever I felt I was able to add something.
No, really nicely done. Irritatingly close to the hour mark as well. I'm always waffling far over it and having to cut things down, but you nailed your first one, so nicely done there. I always find myself coming off the back of those sorts of interviews just with tons of other questions and lines of inquiry to pursue. So if there was another hour coming up, what sort of things would you pursue further, do you think, with Bronnie?
I think one thing that would be interesting to discuss or explore would be, do fibromyalgia patients get fobbed off a little bit when they have normal, in inverted commas, MSK pain, or in fact do they have normal MSK pain in conjunction with the fibromyalgia symptoms? So does someone with fibromyalgia have a new shoulder pain, or are they having a flare-up?
Yeah, exactly. I mean, because why couldn't these things coexist? I think discussing those coexistences and the complexities around that would be quite tricky, but really, yeah, I think that would be quite a good one. And maybe, as you said at the end, both of you alluded to, with getting her and Mike maybe on a future episode as a team and giving them a grilling.
That sounds great.
Go rock, paper, scissors with you over that, since you're stealing the show.
Yeah, well, at least you can have some holiday now.
No, it's brilliant, mate. So, yeah, we've got a couple of other things just feeding into it, haven't we? I've got my conversation coming up with Roger Kerry discussing medically unexplained symptoms. That's going to be an interesting one, and thanks very much for teeing us up there, because I think some of those coexisting pathology problems and things like that I can discuss with Roger in the next couple of weeks. But then,
I'll be looking forward to that one.
Yeah, for sure. It's been called for a lot on Twitter, hasn't it? But me and you have got a bit of a special couple of episodes after that. Do you want to tell the listeners about that?
Yeah, well, we're going to be having a chat with Professor Sally Lamb with regards to a couple of things that maybe some of us come across day to day, in terms of the dogma behind weight-bearing statuses, and when to return people to function post-op, and so even some of the post-trauma issues that we deal with patients, and are these things that need to be challenged now? Do we need to move forward, or are we in the right place? Yeah,
nothing need be sacred. I think that's going to have to be part of the theme. And Sally Lamb, having produced some of probably the most controversial physio-related literature of recent years, so I'm sure she'll be able to get her teeth into those topics. Really looking forward to that. And that's in association with the AOCP, so thanks to them for giving us this lead, and looking forward to pursuing that with you and getting you back on the microphones. But once again, thanks so much for all you've done, both behind the scenes and now on the microphones. But before I let you go, I have to give you a little bit of constructive criticism and say you've managed to talk over the start of Bronnie's cheesy sign outline, which is the most important part of the podcast, let's be honest.
Yeah, of course, and those who work with me probably wouldn't be surprised that I've managed to talk over something quite important.
Well, even though, of course, it only gets sort of a C-, would you like to introduce said cheesy sign outline for us?
Yeah, so let's hand you over to Dr Bronnie Thompson for the now infamous Physio Matters Podcast cheesy sign out.
This is the Physio Matters Podcast, talking physio matters because physio and pain therapy matters.